Well, a warm welcome to this talk. Now, I want to play you the contribution from Mr. Neil Hami, Member of Parliament, in last week's excess deaths debate. And he raises some really powerful questions that are simply not being answered. He talks about persistent deaths in younger and middle-aged adults. This is not a COVID phenomena. This is something else. He talks about vaccine-associated enhanced diseases. And we're simply not getting answers to these questions. Now, he does mention GCP a few times. That stands for good clinical practice. So GCP, good clinical practice. He talks about the impossibility of examining late effects of the vaccines from the clinical trial data. Serious and significant concerns being minimised. Serious questions on how vaccine trials are being conducted. And basically that the government is in, and these agencies are very basically in a state of denial about this. And it's just not coming out. Very frustrating. Your senses frustration when you listen to the speech. I have taken out some of the ruder interruptions that I considered not relevant to the main point he was making. But even so, it does last for quite a while, but it is worth listening to. Questions the Office for National Statistics on record level data. Why has this been released to pharmaceutical companies, we believe, but not to academics and doctors in the UK? Let me say what that means. Your doctor is not allowed access to this data. So there's data that's been released to pharmaceutical industry that's not been released to your doctor or the person who would analyse the data on behalf of your doctor. He talks about the mRNA vaccines. He uses the term metastasise, that it goes around the body. Spike protein systemically going all over the place with consequences, which means that people are no longer with us. So quite a long speech, but well worth listening to. If you can't listen to it in one chunk, listen to it in bits, because it's packed full of really, really quite good stuff. Over to Mr. Neil Hami now.
Correlation, causation, and a relationship between excess deaths and the COVID vaccine, and just remind ourselves of the principles that underpin how clinical trials should be conducted. And the ethical principles that underpin them, that have their origin in the Declaration of Helsinki and are consistent with internationally published good clinical guidance, good clinical practice guidelines, and obviously all of the regulatory mechanisms that fall out from those guidelines. And I've made the point that any agent, if you've been involved in clinical trials of any type, you will know that any agent has the potential to cause injury or harm. That's just the nature of the beast, and one of the things that you try and establish during a clinical trial is to find out if that harm, however minimal it might be or maximal it might be, that you're able either to mitigate it, manage it, or rule that agent out because it is too risky. But that performing that test rigorously is the foundation of GCP. And I make these comments as someone who's been involved in the management and delivery of clinical trials over many years. And I think that, you know, as politicians, as clinicians, and as industry, we all carry a duty of honesty and candour in these matters. Yes, of course I will.
I thank the honourable gentleman for giving way, and with his experience, and he has looked at the Pfizer trial documents, it's clear that Pfizer only actually trialled the vaccines, the experimental vaccines, for 8 weeks in a 22,000 vaccination group and a 22,000 placebo group, and then they vaccinated the placebo group. So how can anyone tell anybody what the long-term effects of these vaccines are when they were only ever monitored for 8 weeks after vaccination?
I think the honourable gentleman, he makes a really important point, and the answer to that is it's impossible. That's the fundamental. You cannot measure late effects if you do not have evidence of that any clinical trial, whether something's ruled in or ruled out, is subject to GCP guidelines. And that's up to the Medical Research Ethics Committee to sign off that protocol. It's up to those, well, you can shake his head, but that's my experience. I've worked in I've worked at UCLH and the Royal Marsden. Those are the principles that we applied in that context. And I can only speak to my experience. I'm not a member of the ABP PI, so I can't give him those types of data. And so, I mean, you know, I'm talking about GCP as a general principle. If he doesn't believe in GCP as a general principle, that's a different discussion. We all understand the situation that we were in. I'm not using a retrospectoscope to say that things shouldn't have been done or shouldn't have been done the way that they were done. But how they should have been conducted should have been absolutely in accordance with GCP guidance, and that's the fundamental crux of the matter. You know, I don't think anybody entered into to do the wrong thing, but there are fundamental questions about how we move things forward from now and whether there was harm inflicted as part of the administration of these agents. Clarifying point, but there certainly are people that I have spoken to who are involved in those clinical trials who have raised very serious and significant concerns about the way their experience after the drug was administered to them and the impact that it had on them in a very acute way was either minimised or written out of the trial data. Now, that's a very serious allegation, and I think that everyone should be interested in understanding the detail of that. That's certainly not what I would understand would fit within the principles of GCP. And so there are serious questions about how the trial studies were conducted. Of course, as the point as the member for North West Leicestershire made, the longitudinal element of that was impossible, and now we're seeing that. But that doesn't mean that we can ignore it. Absolutely not. Anyway, these principles that I've been outlining are there because they are the basis on which good science is established and based upon. I'll just move swiftly on to some of the questions that we must raise and answer today openly and transparently with full access to the ONS record level data. Now, I'm not saying that should be disclosed to all and sundry, but surely the government can't defend its position that it's not willing to release that information to interested clinicians and clinical academics as a minimum. Those are the people who need to be able to interrogate the data. You know, it's of little relevance to me. I don't have the means or the academic ability to interpret that, but it's something that certainly interested clinical academics should have access to. And I want to now move on to what we do know about some of the issues surrounding mRNA technology. We know that it doesn't replicate locally as we were assured it would do on launch. What it does is it metastasizes to distant tissue and replicates spike protein systemically, distant from that site of administration. And that is problematic for a number of reasons, and according to University of London Professor of Oncology and Principal of the Institute of Cancer Vaccines and Immunotherapy, Professor Angus Dalgleish, this has precipitated various serious and sometimes fatal consequences due to antibody development mediated by the spike protein. Now, I'm not going to go into the detail of that, but at a meeting that was convened by the Honourable Gentleman from North West Leicestershire, Professor Dalgleish told us that the UK government and its agencies are in serious denial about this issue, resulting in many deaths being poorly understood. I'll give you a couple of examples. So vaccine-induced immune thrombotic thrombocytopenia is one of the principal causes of blood clot formation, which can cause stroke, pulmonary emboli, and other cardiac-related events, including heart attacks, all of which can be life-limiting or fatal. Another antibody linked to the spike protein exerts an effect on myelin and is associated with Guillain-Barré syndrome and transverse myelitis, which is a swelling around the spinal cord. And Professor Dalgleish believes that this constitutes medical negligence because the facts are there for us all to see, and he contends that many deaths are as a direct result of unnecessary vaccination. Furthermore, he advised us that there are a greater number of yellow cards to MHRA for COVID vaccines than all other vaccines recorded, and nothing has really been done, and I'll come on to that just now. In a recent written answer to me, it was confirmed that the MHRA have received 489,004 spontaneous suspected adverse drug reaction reports relating to COVID-19 vaccine, up to and including the 28th of February of this year. And across the United Kingdom, 2,734 of those reports were associated with a fatal outcome. Of course, the true number, which is the nature of yellow card reporting, is only a fraction of adverse events are reported, is unknown. And that's probably because of limited public awareness about some of the potential consequences or some of the potential complications of vaccine, and that well understood underreporting of those adverse events. But this is really important, because the yellow card system is a key element of safe and effective clinical care. If they're not being evaluated properly, I can think of no greater betrayal of the MHRA's clinical governance responsibility. And I would suggest that accountability for this must be swift and decisive. The rigorous assessment of these data is essential and must be actioned urgently. So I asked the Minister, will she now engage with the MHRA and invite them to come to the House to explain the facts on these reports? Because one of the other issues that arises out of a further written question from myself is in relation to the role of the MHRA itself. We know that they have a crucial role. In fact, they have a statutory function to provide post-marketing surveillance and the operation of that yellow card system. But the Minister has stated in response to my question about the assessment of the potential implications of the British Medical Journal article, Pfizer-BioNTech vaccine is likely responsible for deaths of some elderly patients, Norwegian Review finds, that, and this is and I quote the response, the MHRA communicates safety advice based upon consideration of the totality of evidence from all relevant information sources, rather than the strengths and limitations of individual data sources. Now, surely a fundamental step in any meta-analysis of published data is to interrogate the robustness of those data and for the public to have confidence that that is happening. Now, this links right back to where I started at the beginning, which is around the Cash report. One of the fundamental failings that the Cash report was able to identify was that there was a circular citation amongst various different organisations who were validating each other's position to create a false impression that there was an evidence base to the practice that they were involved in. And it's absolutely crucial. I mean, if the MHRA are going to say that we don't interrogate the data when we do a meta-analysis, then who does? Who's going to do that? Who's going to validate the data? Because I can hand over to the MHRA a whole lot of numbers if they're just going to count them and accept that I've said my methodological rigour is robust. That's not good enough as far as I'm concerned. And the statement from the Minister in relation to that was that the MHRA does not assign causality at the level of individual reports, as this is not the responsibility of the MHRA. Okay, so if that's the case, then whose responsibility is it? Who is interrogating the data? Who is making that decision? And if no one is making that decision, how can we get from correlation to a developed picture of causation or not? And that's an absolutely essential step. And it raises fundamental questions about that responsibility and the reliability of the data that the MHRA are relying upon. And if we're going to learn anything from the general implications of the Cash report, then we must have a very clear steer from the MHRA about how these fundamental scientific principles are going to be observed and upheld. Now, I want to go through a quick canter through some some important published evidence. So in a 2021, this comes back to the correlation causation discussion. In a 2021 study looking at cardiac inflammatory markers in patients receiving mRNA vaccines, Stephen Grundy observed that mRNA vaccination numerically increased inflammatory markers previously described by others for denoting inflammation on the endothelium and T-cell infiltration of cardiac muscles in a patient population receiving the vaccine. A 2022 study by Freeman et al. Noted that the excess risk of serious adverse events identified in their study pointed to the need for formal harm-benefit analysis. This suggestion is wholly consistent with the principles set out in the Declaration of Helsinki and are an ethical imperative. In 2023, a preprint Lancet study by Nicholas Hulcher et al., including leading cardiologist Peter McCulloch and Yale epidemiologist Harvey Reich, reviewed 325 autopsies after COVID vaccination and found that 74% of the deaths were attributable to the vaccine. But that study was published online and then swiftly removed, allegedly for issues with ideological rigour. I wonder if it was the MHRA who did the assessment of its rigour or not. Surely these data, however the problematic some of the methodology might have been, surely these data and findings demand further scrutiny, not removal. In 2023, December 2023, a Lancet Regional Health study by Jonathan Pearson, Stuttert et al. Examined excess mortality in England post-COVID-19 pandemic and the implications for secondary prevention. They state, and I quote, "Many countries, including the UK, have continued to experience an apparent excess of deaths long after the peaks associated with the COVID-19 pandemic in 2020 and 2021. Numbers of excess deaths estimated in this period are considerable, noting the overall trends tend to be consistent across the various methods. The cause of these excess deaths are likely to be multiple, and that further analysis by cause and by age, by sex group, may help quantify the relative contributions of these causes." And I ask this question again, shouldn't we at least be curious about this? They go on. The greatest numbers of excess deaths in the acute phase of the pandemic were in older adults. The pattern now is one of persisting excess deaths in middle-aged and younger adults, with deaths from cardiovascular disease causes and deaths in private homes being most affected. So this is a completely different clinical picture. And timely and granular analysis are needed to describe such trends and so to inform prevention and disease management efforts. Recently disclosed documents as part of a Freedom of Information lawsuit against the US FDA indicate the agency was aware that the safety monitoring system for Pfizer's COVID-19 vaccine was not sufficient, that's quotation, for assessing associated heart conditions when it licensed the company's vaccine. Those documents also reveal numerous manufacturing concerns with Pfizer batches that were released to the public and show the FDA knew about a phenomenon known as vaccine-associated enhanced diseases in those vaccinated who experienced breakthrough COVID-19. And then move on to what we don't know. Well, first of all, we don't have any real progress on the points that have been raised today, particularly around record-level data, and we need that or either the data released to clinical academics and others, or a cogent explanation as to why. And why are these concerns kept hidden by the FDA, and are similar concerns or similar issues being hidden by the UK government? I think some of the points that have been raised about the delay in MHRA taking action on some of the clinical impacts is relevant to that point. And according to a House of Commons library briefing, the government-operated vaccine damage payment scheme, which has been discussed in the last debate and again in this one, only provides a one-off tax-free payment, currently a modest £120,000, to applicants where a vaccine has caused severe disablement. But based on the VDPS claims relating to COVID-19 vaccination, is not routinely published. So we don't have particular metrics that establish how many claims against the COVID-19 vaccine are being made. And the most recent of these is from September 2023. According to the NHS Business Services Authority, they had received 7,160 claims at that time that related to COVID-19. Following medical assessment, 142, just under 2% of these claims were awarded, and 3,030 were rejected. A further 192 claims were found to be invalid, and we need to understand why. What are these claims being measured against, and who is interpreting the clinical assessment information? But we also must ask, are the exclusion criteria reliable given the concerns that have been raised today? At the moment, as far as based on the data that I have here, there were 3,796 currently unresolved claims, 1,010 of which have been unresolved for more than 6 months. And if the 142 successful claims received the full payment, a total cost for that would be around £17 million. And if there were 177 further successful claims among the unresolved cases, this would have associated costs of a further £21 million. I am advised that the government does set aside some funding in relation to this issue, but this has all of the hallmarks of the blood contamination scandal written all over it, and we really need to get ahead of the game and make sure that people get the compensation that they desperately need at a time when it's important to them. And there's another question relating to this, which is why are the government so willing to pick up the tab on vaccine injury and however inadequate the scheme is, given the fatality and significant life-limiting impacts from the victims. But the concerns about this have been amplified significantly following the publication in The Spectator Australia of an account by genomic scientist Kevin McKern made about his accidental discovery, and I quote, "While running an experiment in his Boston lab, McKern used some vials of mRNA, Pfizer and Moderna COVID vaccines as controls. He was shocked to find that they were allegedly contaminated with tiny fragments of plasmid DNA. This concern has been considered further by Professor Angus Dalgleish, who notes that the contaminant, simian virus 40, is a sequence that is used to drive DNA into the nucleus, especially in gene therapies, and that this is something that regulatory agencies around the world have specifically said is not possible with the mRNA vaccines. These SV40 promoters are also well recognised as being oncogenic or are cancer-inducing genetic material. And other scientists have confirmed these findings, as Prof. Dalgleish further notes. To put it bluntly, this means that they are not vaccines at all, but genetically modified organisms that should have been subject to totally different regulatory conditions and certainly not be classed as vaccines." And worryingly, Professor Dalgleish also notes that oncologists have contacted him from across the world and that the consensus is that this is thought to be a precipitating relapse in melanoma, lymphoma, leukemias and in kidney cancers. And he concludes with the following warning: to advise boosted vaccines, as is currently the case, if that's the current position, is no more and no less than medical incompetence. To continue to do so with his cited evidence is medical negligence, which can carry a custodial sentence.
Will the Honourable Gentleman give way?
I will indeed.
I thank the Honourable Gentleman for his contribution and his quotes of Professor Angus Dalgleish, and I'd remind the House that Angus Dalgleish is the most cited oncologist in the UK. I had invited him here to witness this debate today, and since he had some input to it, he can't attend because he's actually speaking at a conference on this very issue we're discussing here in Berlin.
I thank the Honourable Gentleman for that point of information, but also the acknowledgement of a very important scientist in this debate and someone who it's been a great honour of mine to have worked in the same institutions as he provides great leadership in on this specific technology, and you know, his contribution to this problem is and his value to it is impeccable. Anyway, but he concludes that piece by saying no ifs, no buts any longer. All mRNA vaccines must be halted and banned now. So can the Minister answer the following question? Are Big Pharma being exempted from liability, and if so, why? The loss of trust in Big Pharma is substantial, and worryingly, because of this, the value of vaccination itself has been deeply damaged. Personally, I say this absolutely frankly, I will never accept another mRNA vaccine, and I am far from alone. So will the Minister agree to full disclosure of the data and an investigation of the facts? And will the Minister also commit to instructing ONS to release the record level data? Or will it take someone like New Zealander Barry Young, a whistleblower who has been imprisoned for publishing their record level data, to surface his concerns about the COVID vaccine programme in New Zealand? As we've seen with the Horizon scandal, government must never bury the facts when lives are being lost and futures destroyed. There is no greater betrayal. So in closing, the foundation of good clinical practice are under threat, and I put that into context with the December 2023 Pathology Research and Practice paper on gene-based COVID-19 vaccines from Rodeza and Parry, and they gave this following warning. Pandemic management requires societal coordination, global orchestration, respect for human rights and defence of ethical principles. Yet some approaches to the COVID-19 pandemic, driven by socio-economic, corporate and political interests, have undermined key pillars of ethical medical science. None of these clinical experts are quacks or conspiracy theorists. And as the government has said so often during the pandemic, we must follow the science. Thank you, Mr. Deputy Speaker.
Thank you, Mr. Deputy.